The general idea that epidemiology plays a key role in the risk assessment is something which is quite well assessed since the very beginning of this practice, which is in the, let's say, 50 years ago. And if you look at okay, that was just the introduction of the lecture, which is on the role of epidemiology in the risk assessment, especially in key steps in risk assessment. And however, what are these key steps? I'm sure you have already received a lot of information about this procedure. However, it's quite clear that, and this is it's actually the topic of this lecture, of the lessons is the role that epidemiology can have in different steps of the key of the risk assessment, which is the hazard identification, or at least in this declination, those response assessment, exposure assessment, and the characterization of risks. And actually, if you look into this paper, which is nearly 15 years, no, it's 15 years old, 40 years old. And it's quite clear that if you look at what is the activity associated with hazard identification, the assessment that there is a dose response between exposure and effect, of course, and that we have to assess the exposure and to characterize the risk, especially this last part in which all the information put together is collapsed to create a risk. So to identify a risk. When we talk about risk, we enter the kingdom of epidemiology. And so, well, let's try to define one moment, a little better, the association between the risk assessment, the use of epidemiological methods in risk assessment. And let's see that one of the key procedure at the end of the story of risk assessment is to establish if there is an association between an exposure, maybe environmental, maybe occupation at workplace, and a disease or an effect or a change in the health status of the population which is exposed. I mean, this is actually the key questions of any risk assessment process. And the point is that what we need to perform this assessment. Well, of course, we need first an exposure that we can measure or estimate. This is quite complicated issue. We will see now a little examples, although there will be a special lessons on this topic. Then once there is an exposure, we need a model. We model linking the exposure to the effect. It is the pathway linking. So we need to establish a number of mechanisms. And it is actually what is doing the molecular epidemiology and molecular biology, molecular genetics, toxicology, and so on. Then we move towards the real kingdom of epidemiology, which is the definition of exposed population and possibly of an unexposed population, which is the control group. And then the final step, which is the identification, the definition of a measurable effect, which is associated, plausibly related to the exposure. So these are actually, that's very, very simple, an oversimplified definition of different steps in assessing the link between exposure and effect. But I would say that it summarizes what are the key steps actually, because actually there is a number of definitions. When you define each of these steps, there is a word behind. Think about exposure assessment. So what are the procedure to define to say that there is an exposure in a particular environment or in a particular workplace? And there is obviously several approaches. You can measure use biomonitoring to measure the presence of exposure in the individuals, or monitor the environment with specific devices, or you can model the presence of exposure. You can extrapolate. There's a number of approaches. This is not the right lesson, so I don't know what I will not go through this, but however, I wanted just to tell you that pay attention also to next step, which is you remember the establishing of a pathway linking uh, exposure and the disease. On this regard, the role of molecular epidemiology has been really important since actually, at the very beginning, when there was a transition between traditional epidemiology to molecular epidemiology, we spoke a lot about the idea of a black box. I mean, which there you have an exposure, and here you have an effect. You don't know anything about what's inside. But the validation, the progressive use of biomarkers has helped a lot in understanding different steps. So nowadays we have enzymes that activate some exposure needs activation, some can be fully detoxified, and there is genetic susceptibility and so on. So actually, there is a word inside that black box, but we are not talking about that. We move to different topics. One is the definition, the identification of the exposed population, and the second is the measurable effect linking the 2 points. Identifying the population is mostly work for descriptive epidemiology. So we start now a little overview, very short overview of main methods, study design, and that can, especially study design, that can be used in risk assessment to identify the population, to identify the exposed population, to identify the control group, and to estimate the risk associated possibly with a dose response. So the real point of descriptive studies is to identify the population, to define, okay, this is another important issue, to define the disease under study. In some cases, may be quite simple. Think about myocardial infarction or lung cancer or I mean, there are a number of diseases or conditions that can be easily defined. There is most of health status or even some diseases that can be hardly defined. Think about, I don't know, metabolic syndrome or schizophrenia or frailty or even flu. I mean, there's a number of diseases in which you need to be really strict about the criteria that identify a case. And then there is the core business of epidemiology, which is describing the disease using the time, the place, and the persons, which is a classical paradigmatic definition of epidemiological approach in which you study a disease, you study the evolution of the disease in time. So they are studying trends of disease. A disease may increase, may decrease, and from this observation, you make etiological assessment or hypothesis. Then places, where there are places in which there is a higher incidence of a disease, other which is the lower incidence, very high, very low. So from the reading the geographical map of disease distribution, you can get a lot of information. And the same persons who is going to get the disease, who is going not. People may be exposed or not exposed, may be genetically susceptible, maybe not. So you understand it even from just a very simple bullet list like this can open up to a number of huge topics. Then we have, once we have described, defined and described the disease, we have to measure the disease. We will be brief through that, talking a little bit about rates. Then, once we have rates, you know how frequent is a disease to compare this disease with known historical frequencies or people, different countries, different periods, different places. And then out of these steps, we can formulate an etiological hypothesis. This is the role of descriptive epidemiology. Once we have an hypothesis which is surrogated by different evidence, like the one that I'm talking about now, you move into the realm of analytic epidemiology, in which you are going to study, to assess this hypothesis. Let's talk a little about the measure of frequency. And this is clearly important because before any trial, before any study, we have to provide a big picture about the disease. So we have to describe the frequency, and that may be the relative, but also the absolute frequency. So how many cases and what's the population these cases come from. And actually, when you talk about that, we have two main measures, prevalence measures, incidence measures. And they have different purposes, and they provide different pieces of information. Talking about prevalence, this measure helps to describe the current burden of the disease. So it's especially important to say how many cases of this disease is present on our territory. I mean, there is so to know how frequent is the disease in a special area helps to allocate resources, create clinics, to invest money in prevention, to invest money in the clinical and sanitary staff that can take care of the people with the disease. And the way of calculating is quite simple, and because we have just that's a simple ratio between the people with the disease in a certain period of time to the people living, residents, or we can say at risk of getting the disease in the same area in the same period. So once you have this ratio, you can just use a standard measure, maybe multiplying by 100, by 1,000, by 100,000. And so you have a measure of the presence of the disease. So you can say, okay, in this area, we have to start with a preventive campaign because the frequency is increasing. A little difference is the meaning, not the little difference is the meaning of incidence. Incidence, which describe the number of new cases in a specific period of time in a specific area. And that means a measure of there's nothing to do with the efficiency or effectiveness of health system in that area, but it's dealing with the risk of the disease. And so we want to we study the incidence of the disease, especially when we are interested in the causes and reconstructing the mechanism of the disease and to have an idea of how many new cases of that disease we have in a specific period of time. And as written here, the formula is quite simple. You have to define maybe from January the 1st to December the 31 of one single year. So we have a period of time, and we have now all new cases occurring in that area. But this is not really the incidence rate. This is called a cumulative incidence rate because put together and consider all people like staying, if is an observational period of 1 year, for instance, is like everybody stays in that area for 1 year and they are at risk for 1 year. But this is good in large population and provide a general piece of information. But when we move to smaller population, that's quite clear that there is that not everybody contributed to the same follow-up in the same way. Just imagine 10 people followed up for 6 years. There are some people entering just the second year and getting the disease at the fifth year. So these people will be in observation not for 6 years, but only for 3. Someone entered at the very beginning of the study and never developed the disease, and so his observation time contribute for 6 years, and so on. You have people, for instance, this one, number 2, enter the first year and die of the 5th year. So if you die, you cannot get the disease. So you cannot contribute to this final period. So this is to introduce you the concept of person time. So each person contribute for a specific number of years. You can hear overall we have 46 years contributed by these 10 people, which is exactly the same like one people or 46 people has contributed for 1 year. So we use this to calculate what is called incidence density or real incidence or the incidence rate. So, which is the number of cases to the number of person years. For instance, in this case, in this example, incidence density is corresponding to 0.009 case per year. Just imagine that if you have used cumulative incidence, so you have 4 cases out of 10 people, so 40% is one case, 0 per 9 per year is it. You understand, which is a completely different approach. But obviously, incidence density is the golden standard. So if you do a wrap up, you see that there is a number of different issues, advantages and disadvantages dealing with incidence, which takes new cases, requires the follow-up, so it's more expensive, is not associated with the duration of the disease because you are measuring new cases, whereas prevalence is strictly associated to the duration of the disease, especially if you measure a time point estimation of prevalence, like to say, what's the prevalence today of diabetes, type 2 diabetes? Or what's the nowadays the prevalence today the prevalence of maybe pancreatic cancer. So you see that in one case you have a very high prevalence, in another a very low prevalence because the duration of diabetes is very long, whereas the one of pancreatic cancer they have a short survival, so the probability to get a case is much lower. So you have to plan. You can keep the slides so and reread it. But however, it's quite clear that these two measures have a number of different advantages and disadvantages, and they are very an important tool for all the initial steps of risk assessment. When you have to define who is exposed, how many are exposed, who is not exposed. When we have started with this basic information, which are mostly dealing with what is called non-control cases, which are case report, case series, descriptive epidemiology. So we have formulated an hypothesis, a study hypothesis that can be further investigated in the laboratory and with animal studies, but we are mostly interested in analytic epidemiology. Analytic epidemiology can bring us to clinical trials, intervention trials, which is something which is not dealing with risk assessment. So you have to go through this slide and focus on analytic epidemiology and the classical case studies, which are cohort, case control, cross-sectional studies. So briefly, I talked to you about descriptive studies, which is very classic approach, and also in risk assessment, because case report is the observation by the investigator that something is not going well. So there is a number of unusual occurrences. And then if there are some strange cases of maybe a symptom, maybe dermatitis, maybe dizziness, maybe or some specific cases, that unexpected cases. Then the next step, which is case series, is the observation that there's not only one case of that strange symptom, that strange disease, that unusual disease, but there are many. And so the example here, for instance, is the first cases of AIDS in the US, in which with only 1,000 cases, just the description of these cases was enough to understand the complication and etiology of this disease. And then obviously I anticipated already the basic of descriptive epidemiology, in which, for instance, in this case, you see the death by asthma that were not changing a lot in the USA or in Sweden, where especially in the USA, where it is prevalent the Los Angeles type air pollution, mostly due to traffic, but was very different in London at the beginning of the 60s, between the 50s and the 60s, when everybody started to have home heating based on carbon or wood. So a lot of particulate that was really lethal for people with asthma. And but however, moving to as I told you, the observational analytical studies, we have to deal with in the next step. This is really a critical point in risk assessment, in which we try to establish if people exposed actually develop the risk. And there are cohort study, case control study, and cross-sectional studies are the very typical approaches. And the cross-sectional study is the most popular because it's easier, because it's much less expensive, and can provide the results at present in very short time. So you put together the study population, and in the same time, you look in the study population, who is with the outcome and who is without, who is with the risk, who is without. Like if you go in in a school and you ask everybody how many, what's your BMI, how many times you drink carbonated and rich in sugar drinks. So you have the same time you put together, and you have the risk to be overweight if you drink this kind of drinks. And okay, in this case, maybe may work. In many cases, it's not so easy because the problem with reverse causality is the main one. So you don't know if it's the disease to cause the effect or the effect. What's the cause actually? But in many cases, there is a clear evidence. So in many cases, this study works very well. You can establish a risk associating the effect, the cause, and the exposure. However, the golden standard for this kind of study instead is the cohort design. The cohort design is the most robust approach in which why is robust? Because when you start, everybody is healthy. You check the study population, you remove everybody who has already the disease, then you classified people with the disease, maybe people living near a plant, solid waste, urban waste plant, maybe or near to an incinerator, and people living in the countryside in a different area. So you classify people now when all of them are healthy. Then you follow them up until you see an enough number of diseases to estimate what is called a relative risk, because you have the incidence of disease in this group, the incidence of diseases in this non-exposed group, the ratio of incidences in the two groups reflect the relative risk. So this is the most expensive, but also the most reliable analytical observational study. The final exam, the final study is the one that epidemiologists likes more, is the case control study. Is a very powerful study because you start from now dividing people with the disease outcome or people without the disease. You start now, And you interview these people, reconstruct the exposure to these people. So it's very powerful because you can do it right now. You get to get a longitudinal assessment of the risk. The major problem is bias because you have to select the population, and it's quite easy that people with the disease select by themselves and maybe by social status, by education, or whatever. And when you reconstruct the exposure, the condition of being the disease with the disease may bias again the exposure assessment. So it's very powerful study design, but it's really risky. And what kind of risk we measure out of this study? We can measure absolute risk, but we do it especially with the rates that I anticipated before. The typical result of these studies are the relative risk or the odds ratio, which are measures that associate that provide information about the strength of the association between an exposure and effect. Generally is a ratio. So when the relative risk of the odds ratio are equal to 1, it means that there is no difference in the incidence of the proportion of exposed in the study group and the controls. No different, so the same amount in the ratio, so the relative risk is 1. If there is a higher the prevalence or the incidence in the exposed population, the risk increases. It's more than 1, and so provide a lot of information because obviously a risk of 1.1 is much different from the risk of 2 or 3, and so pay attention, don't trust completely p-value, but look more first to the extent of risk, relative risk especially, but also odds ratio. Another measure of risk that can be estimated from this study design is the attributable risk, or the fraction, the attributable fraction, in which you attribute to a specific exposure the responsibility of a determined amount of cases, in absolute number or in proportion. And so when you say in some cases for public health may be really important. Think about how many lung cancer cases are due to smoking. Maybe 80%, 70, 90, a lot. So that are really important for planning, for deciding the next health control strategies. Nowadays, with the use of the more and more common use of biomarkers in this kind of studies, a number of new study design has developed. And in many cases, they are called smart study design, especially because biomarker analysis can be time-consuming and expensive. And there is a problem of bias. In some cases, you have just a few cases and a lot of people, so you cannot screen thousands of people with very expensive biomarkers to investigate just a small number of cases. So the smart design must be efficient, valid, and reliable. I have no time to go through the detail, I just show you a couple of them. One is case-only studies. So you can invest, you have a study population in which you have people with the disease, people without the disease. You may investigate it only with people with the disease. And so investigate, for instance, if people exposed have a different pattern, different clinical feature of different severity of the disease. And so you can make, this is a typical has been done in infectious diseases, in which you investigate if different clinical feature of the same disease may have different bacterial strain, for instance. And this is very important, useful also in toxicology of chemical factors. Another very popular one of the first is the nested case control studies, in which this is a very smart approach. in which you start from a cohort study, in which at the end of the study, you have, at the end of the follow-up, you have a small number of people with the disease. Maybe if you investigate maybe 10,000 people, you can have 200 cases and 9,800 known cases. So if you want to compare them with a biomarker, what to do. So you have to investigate 10,000 people just to get the information only from 200. So to save this situation, the nested case control study, what it does, use all the cases with disease and a random sample of known cases, possibly matched with the cases. So at the end of the story, in the example that I made, instead of 10,000 biomarkers measurement, you can investigate 200 people with the disease and maybe 200 people without the disease, which are, however, representative of the whole study group. So you see that in this brief overview of the use of epidemiological methods and how they can enter to the they can enter to the procedures for risk assessment, I cannot say that there is some discussion about epidemiologists and toxicologists when they started defining the risk assessment, because what epidemiologists said that different steps of risk assessment are something which are mostly dealing with epidemiological steps. So epidemiologists did this already before you invented risk assessment. So there was some debate, like assessing dose response relationship between exposure and risk, or especially hazard identification seems not easy to be distinguished from assessing causality, which is a classical point that comes at the end of epidemiological study, or risk characterization, which is similar to. The point is that it's not a matter of methodology, it's mostly a matter of application. In a way, the epidemiological approach is mostly dealing with research and more, no, I wouldn't say a theoretical approach, but for sure is approach with dealing with more science and assessing new risk and assessing, providing information, that evidence that can be used for risk assessment in general, for evaluation of etiology of the disease, whereas risk assessment has a strength grip with the real life, in which since provide the use of this evidence can change the life of people. So the point is that that should be given. This is the point of view of toxicology that in a way I share. That is that must be provided to the epidemiologists more education about the application of their results. And especially they must learn about the use of epidemiological evidence in policy making, and especially in risk assessment. The point that that would be great to have in the education of epidemiologists, also to provide information about, here is called policy making arenas, which is actually something very critical. And if I can conclude, is that obviously the participation in epidemiology and risk assessment is unavoidable, because I mean, they are the epidemiologists that can actually make the estimation that are very useful for risk assessment procedure. On the other hand, the point is that epidemiologists should, in a way, go out of their approach, which is dimensionless, which is not. They have to have to put their hand in the real world to change their approach. And this is what I wanted to share with you, and I hope that you have enjoyed. And if you are epidemiologist, you have a more careful sight into the real world. Thank you very much.